to invite the chairpersons for the next session, which is the oration session. I'll request Dr. Dinesh Sharma sir to please come. Dr. Rajesh Tiwari, you can come to the dais now. I mean, please come, sir. Dr. Sanjeev Mittal and Dr. Anand Vardhan, and I'll request them to take over the proceedings from here.
इसको मैं बंद कर दूं थोड़ी देर के लिए क्या रहने दूं ऐसे I'll just see this. So we start with the most important part of the session, the oration part. I will start with a share. फैले हैं रंग देखिए हर एक समत मीन दिशा मसाफे जीस्त को वो खूबसूरत पल है आज means struggle of life that leads to achievement and success, and that is the moment for today for the Drishti Eye people. I would like to congratulate the Luthra family and the entire staff of Drishti Eye Institute on their 25th anniversary. We must also know the man behind the inception and growth of this institution. Dr. MC Luthra Sahab was totally dedicated to the profession, soft-spoken and a humble personality. Born in Allahabad, got his medical education, both graduation and post-graduation from SN Medical College, Agra, and after completing his post-graduation in ophthalmology, he moved to his Karm Bhumi, Dehradun in 1968 and started his career in ONGC, from where he took voluntary retirement in 1996 as the chief eye surgeon. His accomplishments were not limited to his profession. People who know Luthra Sahab would remember that he was very active academically. He used to participate as well as organize numerous conferences. He was one of the founding members of the Dehradun and Uttaranchal State Ophthalmic Societies. He believed in giving back to his roots and organized almost 200 eye camps under the banner of IMA, Rotary Club, ONGC, and other organizations. He also established the IMA Oxygen Bank and the family planning camps to promote the overall health of the community. For his achievements, he was awarded the Lifetime Achievement Awards at the Uttarakhand State Ophthalmic Society Conference in 2008 and North Zone Ophthalmic Society Conference in 2016. Both his sons, Gaurav and Saurabh, with their hard work and dedication, have taken the establishment to new heights. And we hope and pray that the next generation will follow the footsteps of their father and grandfather to make it a world-class facility. Thank you.
Can I have my slides, please? Yeah, it's happening. Thank you, sir, for your blessings and for the introduction. And we are really thankful to all the chairpersons of this session for gracing the occasion. we all know Dr. M.C. Luthra. I won't go into these because Sir has nicely, enumerated that. And the Dr. M.C. Luthra Gold Medal Award, also in UKSOS, was instituted in his name in 2002, and he was very active in Rotary and IMA. So the past recipients of Dr. M.C. Luthra Oration was Dr. Akar Grover in 2013, Dr. Mahipal Singh Sajdev in 2014, Dr. Kumar Doctor in 2017, and Professor Amod Gupta in 2018. And we are very proud to present this oration this year to none other than Professor Jeevan S. Titiyal, who is a professor of ophthalmology and chief at Dr. R.P. Center for Ophthalmic Sciences at AIIMS. And he has a huge CV with more than 400 publications, more than 7,000 citations, 6 books, and more than 60 chapters, delivered more than 50 orations and keynote addresses, and regularly conducts instruction courses in various international forums like the American Academy, SCRS, European Society of Cataract Surgeons, and so many others. Amongst the top cited researchers in 2021 ranking in ophthalmology in India, according to Stanford University, has 2 patents to his credit and has several international awards and honors with the Distinguished Service Award of the APAO, the Senior Achievement Award of the American Academy and Asia Pacific Academy, and the first Indian to perform live surgery in Ascaris, USA. And he was awarded the Padam Shri by the President of India in 2014, the P. Siva Reddy International Award by the AIOC, and the R.P. Dhanda Award by AIOC, 4 gold medals. And he has been the president of the Indian Society of Cornea and Keratorefractive Surgeons and the past president and secretary of DOS. So with these words, I now invite Professor Titiyal to please deliver his oration. So we would like to honor him first and then followed by his oration. I would request the chairpersons of this session to please come forward and honor him with the oration.
Dr. Titiyal sir, 1 minute.
So Dr. Tiwari sir wants to say a couple of words before sir starts his oration.
आज सौभाग्य का विषय है कि हमारे प्रोफेसर टिटियाल हमारे उत्तराखंड के ही सुपुत्र हैं और भारतवर्ष के गौरव हैं और ओजस्वी वक्ता हैं। राष्ट्रीय और अंतर्राष्ट्रीय मंच पर जो नेत्र विशेषज्ञों के मंच हैं वहाँ पर डॉक्टर साहब एक लब्ध प्रतिष्ठित नेत्र विशेषज्ञ के रूप में विख्यात हैं और आज हमारे मध्य हमारे सबका मार्गदर्शन करने के लिए उपस्थित हैं। मैं सभी की ओर से डॉक्टर टिटियाल का स्वागत करता हूँ।
गुड आफ्टरनून, नमस्कार। बहुत बहुत धन्यवाद कि आप लोगों ने जो है इतनी बड़ी एक सम्मान हमें दी है। तो इट लुक्स लाइक आई एम इन वेरी डिफिकल्ट सिचुएशन to make everybody feel comfortable with the scenario which we are going through today, and especially after that video theater, things have changed so much. People are seeing in a more depth, more stereoscopically they are seeing better. I hope that I can make things more visible. I'm really thankful to Uttarakhand Ophthalmic Society, State Ophthalmic Society, Dehradun Ophthalmic Society, and Drishti Group Institution for organizing this CME and giving me this honor to deliver this very prestigious Dr. M.C. Luthra Oration. And it is really from my heart that I feel honored because I've known Sir for a very long time. My initial interaction with him started in 1991 when he was in ONGC and holding the one of the more important, I think, positions in this country society activities, mainly in UP State Ophthalmic Society at that time. And remember one small, I think it was to be a monthly meeting or something like in Saharanpur. I met him and we had a session on ultrasound. I still remember there were discussion on ultrasound on that day. And I happened to do a eye camp at Saharanpur that particular evening. So that is how we started, and subsequently my interaction with him been so lively, and he was like, a guiding force to everybody, including me also, and really privileged to deliver this talk today. And looking back, the entire generation, Gaurav and Saurabh, I've known them for a long time, and they're doing a wonderful work. And more importantly, they are making us proud everywhere. I see them not only in the country, across the world, they are there, and people know them, and they are from Uttarakhand. That is the one best thing. And they established the scenario which controls few things. One is the love of people of Uttarakhand, and giving them back with the technology and the expertise. There are two important things which we want from any medical institution in any part of the world. And if they can deliver the expertise with the technology, that will be best for the society. And I know that our people are benefiting with that. Not only the patients, the medical fraternity also. With that, I'll start my talk. I'd like to be as brief as possible because we are at least going a little slow in that. I thought, let me talk something more common for our people here. We have students here, we have ophthalmologists who are doing a routine surgeries. So why not to talk something more on a cataract? I thought, let's discuss something which are very routinely done. So I'll be talking on some of the difficult situations which can be handled in a nice manner, comfortable manner to achieve a good results in these cases. No financial disclosure from this talk. So there'll be a certain things which are important for life. That is giving something to the patient where they can appreciate better. That is in cataract relation, giving them a vision which is comfortable. That means they can see every distance clearly and come out with the surgical trauma in a manner where they don't have pain, they don't have the post-op difficulties, and do good work for themselves and their family also. So routine cataract surgery, we hardly have challenges. All of us are doing a good surgery in those cases. There'll be certain scenarios where things can be difficult right from the beginning because those are difficult cases. Or sometimes we create difficulty during the surgery also because of some steps going in a manner which is not controlled, and that creates a future problem for during surgery for these patients, and you may have to change plan for a patient. I'm saying this word change in a plan of surgery is very important for younger people also. Suppose we have a patient where we have discussed, counseled, and planned for a trifocal lens for that patient. And you have a huge PC rent and you can't implant the trifocal lens because you don't get a trifocal lens in a three-piece design. So you have no option there. So you may have to shift to a monofocal lens there and do a good surgery and do everything clearly, but patient will not be happy. So if that situation comes up, we have to talk to the patient immediately after surgery. Because of this problem, we had changed the plan, and this is the lens we have put, and you'll be quite all right. So next day, patient know that the surgical plan has been changed, and this is my perception. Rather than next day, patient saying, I can't see near. So there are certain situations, despite completing the surgery comfortably, from your side, you need to talk to the patient. Many of the time, we don't talk to the patient that immediately after surgery. Most of the time, we talk to them next day. And next day, sometimes very comfortable where patient sees what we have promised, and sometimes patient don't see, then you have to counsel those patients. So these are situations created by the situation, that is intraoperative situation, how to handle those areas. So these are difficult situations which I might cover in my presentation. So let me first go to my own area of endothelium, because we do a lot of triple procedures. So how do we decide which particular case of endothelial compromised situation requires only cataract surgery, or it requires a triple procedure, or it requires a sequential surgery for these patients? So there are three important aspects for deciding what should be done for these patients. Apart from looking into cornea, which has a very nicely prescribed guidelines to pick up how to proceed for those cases, two other important areas has to be considered. One is the patient's symptom. If patient is symptomatic, that means patient has a visual problem, patient has a morning blur which is extending throughout the day, and patient has the night driving difficulties, and also has a cataract. In cataract also type of cataract. There may be a nuclear cataract where contrast would go down, and if cornea is compromised, the contrast would further go down. You have a posterior subcapsular cataract, so you may have to handle differently. If cataract is more prominent for a visual loss, patient might be happy with only cataract surgery. But these are guidelines. The corneal thickness is second important guidelines. If corneal thickness is much more, in Indian scenario, if it is more than 580 or 600, patient may require endothelial transplant surgery. But thickness will be modified by the appearance of a specular reflection by slit-lamp examination, or specular microscopy to be done to see number of cells and the type of cells in those cases, especially looking at CB those cases. So we do a phaco alone if you have a good corneal thickness, a good specular count which is more than 1000, or we do a combined surgery, a sequential surgery, because sometimes people like to wait and then decide how the cornea behaves, and then subsequently refer the patient to a transplant surgeon to get a surgery done, because most cataract surgeon may not have access to a corneal transplant technique or availability of cornea also. So accordingly you can decide your patient. So this is one patient of corneal fuchs, and we are doing endothelial protection, which is compulsory to be done for all cases, more for a difficult situation, hard cataract, small pupil, or an endothelial compromised situation like this. This is a dispersive viscoelastic, which is put inside the eye first. Now subsequently this dispersive viscoelastic has to be pushed towards the endothelium. So this is a cohesive viscoelastic which is being injected. Therefore, the dispersive will coat the endothelium, which will remain for the entire duration of surgery. So you have two waves now, because now we have a very, very tight chamber. We are putting the little bit of BSS under the cohesive viscoelastic. This is a triple soft shell technique of Arsenov, where you can do a now good rhexis also, because if you have a oily type of thing, then flap rotation becomes difficulty in a dispersive viscoelastic cover. So we have a fluid here that the entire rhexis will be more comfortable now. We can easily do a rhexis and complete surgery in this case. So this is the advantage of viscoelastic use in a different manner. The triple soft shell techniques should be used in cases where you have endothelial compromised situations. But sometimes we like to do a rhexis first, then do a soft shell technique. There you can just do simply a double soft shell technique in those cases. If you have an excessive femtosecond laser, nothing better than that, because that will decrease the requirement of things, and these are published results from our side also. Femtosecond laser does decrease the phaco energy, the surgical time, and the endothelial protection is better in these cases also. So all cases with Fuchs rhosopy do have a challenges also. This is the classical Fuchs patient with the increased corneal thickness. You can see endothelial reflection is not very clear, thick endothelium. You can see a gutte also in a microscope also directly. So I'll take you towards the end of surgery in this patient. This is the phaco being completed. Now I'm putting intraocular lens, which is normally hydrophobic lens for these patients, because sometimes these patients may require endothelial keratoplasty, where if you put a hydrophilic lenses, sometimes the air interaction can cause lens to become opaque. So hydrophobic lenses should be preferred here. So this is the end of surgery here. I thought everything is okay now. I'll hydrate my wound here. So I thought I'll see with the OCT microscope. Then I realized there's a detachment in the wound side area. And you can't leave this in a Fuchs patient. So I just looked again. I thought it looks quite all right. Let me shift my cursor towards the central area. Then I realized the detachment is already going towards the central area also. So if you don't have this access of OCT, you would have left this patient like this, and next day morning cornea would have been white. So this difficult situation I could manage because I could see, I could suspect. Because there are certain cases like a Fuchs patient or a deep set eyes, long phaco, very hard cataract, small eyes, you can have a detachment in the wound area and it should be suspicious. And look for a frill which can be visible under the microscope also, and manage that situation here. So the day can be saved by visualization as such. The point to remember in a fuchs patient is soft shell technique in the bag phaco. There are more chances of DMD in wound area, always look for that. And if post-op you have a little more edema, whitish thing, do an anti-segment OCT to rule out detachment, and if it is there, you can inject air bubble and you can save the day for your patient. So that is another way of looking for these cases also. Let me take you some of the important things for small pupil cases, because if you do 100 cases, there will be at least 10 to 15 cases which will be difficult for you with a small pupil or a poorly dilated pupil or a floppy iris in these cases. The pre-op medication is very, very important. Nowadays we use all these anti-inflammatory drugs to maintain the dilatation, decrease the pain, decrease the inflammation also. You have access to a BD dosing or OD dosing of these anti-inflammatory medications. This is our study where we compared BD versus OD dosing, how effective they are in terms of AC concentration in a series of phaco cases where we took out the aqueous of these patients at different times of drops and realized their concentration is effective to be there within a 12 hours also. So daily dosing of one drop is effective in these cases, should be done a long time. So whenever we are dealing with a small pupil, we have to realize what type of pupil we are dealing with. It is a floppy iris pupil, or it is a rigid pupil, or it is a completely pharmacologically dilated pupil. So normally all these cases, this is, you can see, around 5 to 5.5 millimeter pupil. I have done a incision here. As soon as I inject the viscoelastic, I realize this is little floppy. That means the pharmacological dilation may not have been complete. In such cases, intracameral medications you can see the iris being floppy here little bit because you saw it here. I'll put a little bit of cohesive viscoelastic. Whenever we have to inject intracameral drug, it has to be under the viscoelastic cover. So I'm injecting little fluid here. You can see the pupillary dilatation. So nowadays you have Phenocan type of medication which has everything, or you can simply use the diluted adrenaline, and that can give you access for a good maintained sustained dilatation. So don't jump for devices in the beginning. Look how effectively you can dilate this pupil and you can complete a surgery without any difficulty also. So this is one pupil which is rigid. I'll show you this. Actually, this is not working here. So this is a small pupil which was rigid, and with viscoelastic elastic injections and the intracameral injection, it did not buzz. Therefore, I thought I can do this complete surgery without any device being in this particular case. So here, important thing is to realize, I'll take some time because this has got hang here. So this can be completed surgery without any difficulty also. So this is the third scenario. You have around 3.5 millimeter pupil. AC should be well maintained during every procedure so that pupil doesn't get floppy. Dilatation must. I realize this is a case which required the expensive device. Most people sitting here would be comfortable using the iris hooks for a pupil expansion rather than devices. So this is my technique of putting 6 hooks, which makes the hexagonal appearance of a pupil and makes things very comfortable. You saw I made of 6 incisions first. They are little posterior so that they don't tend the iris. Then subsequently I'll place all the hooks over the area, then one by one I'll inject, and one by one slowly stretch them. I don't stretch completely at one go so that there's hardly any stress. So 2 are more important ones. One is just near to your visual axis of phaco, and one subincisional. And this gives you a nice option for doing a good rhexis of around 4.5 to 5 millimeter. Because small pupil cases, sometimes rhexis is very small, and ultimately they'll have a phimosis and have more complication in long run. So you can see I could complete rhexis in this particular case, and you can complete surgery now very effectively without any difficulty also. The idea is to have a nice opened area of surgery and decrease the damage to the pupil and complete your surgery as such. You can see here I completed the entire phaco here, taking out the cortex here, and you can see a very nice rhexis, and you can implant the IOL of desirable size also. So this is the scenario where you can have more difficulties if you have a nucleus, softer nucleus, harder nucleus, all types of nucleus will have a difficulty in a small pupil. So I'm dilating the pupil here under the viscoelastic. I thought this is quite okay. With the pressure, the pupil dilated to 4.5 millimeter. I could do rhexis completely in a manner where I could achieve a required size. And sometimes you may have to use the hybrid techniques. Initiate with the cystitome, then complete with your forceps. I normally use ILM peeling forceps for my rhexis. You can use any other instrumentation. So this was a very, very hard cataract, and pupils started constricting. So don't wait for the pupil to constrict that much where you can damage the pupil with your phaco power. So this is the time you have to shift to alternative devices, and this again you can put the hooks in these cases and complete your surgery. So don't really wait for things to get complicated. You can change the scenario to the beginning of your surgery and manage. So your hard cataract, you require a larger area for visibility. You can do subsequently things here. So NSAID saves a day for floppy iris cases. Atropine I don't use for even patient with the prostate patients also. And make sure intracameral medication are available that can decrease pain, that can maintain the dilatation. Always use low flow surgery for these cases. Just subluxation wise, I think Gaurav showed very, very nicely these cases. Femtosecond gives you an advantage of doing everything in a closed chamber wise, which is very, very important, because once you open the chamber, subluxation can increase. So this was the patient, you can see the OCT now subsequently. Had the, this is the, you can say, corneal side where it got managed. This is the vitreous block had in the anterior chamber. So similarly, as Gaurav showed, even you have a vitreous, you can do a femtosecond application and do a rhexis comfortably here. So I could complete the rhexis. You can see the gel happening because of vitreous in the anterior chamber, and it was a complete rhexis subsequently. I could release the rhexis without any difficulty. Again, making the posterior incision for maintaining the capsular back integrity. If you do a little posterior incisions, there's no tenting of rhexis, and chance of damage is also less. The femtosecond capsulotomy also can resist. They are quite strong, and you can use the hooks and complete surgery in these cases also. Before you do a phaco, you have to remove the vitreous, which the block is there. I'm doing under the tamsulosin acetate staining. Complete my vitreous management, remove the nucleus and implant CTR, and you complete the rhexis also. So this is one patient which you might see in cases with the high myopic patients. Pupil well dilated, it is a hard nucleus. I could do a rhexis of around 5 millimeter size here. Even I could do a nice hydro procedure here, but see what happens during a phaco surgery here. I'm doing a chop here. The entire bag is floppy and is moving absolutely like it will go down as soon as you continue pressure here. And see, you will see here now the bag movement. You can see the entire bag is moving, because even if the bag is loose, despite doing a hydro procedure, rotation may gets difficult here. So how to manage this case here? Either you can put a CTR or manage the hooks to maintain the rhexis margin. So if you have a stained capsule, you can see the rhexis margin, and you can use any device in these cases. For a beginners, all capsulotomies should be done under staining, despite having a glow also, so that during the subsequent procedure you can see the rhexis margin and complete your phaco in these cases. So I have put 5 hooks here to maintain the bag integrity, and subsequently I'll complete the surgery here. Just to go towards the end of surgery, as you can see, nicely completed, but this bag is totally poorly supported by the weak zonules. So it's not a good idea to implant lens in the back. So what I'm going to do here, I'm going to implant lens in the sulcus, like you saw in a patient with PCR, and then capture the IOL into a rhexis. So both supports will be there. So I'm putting lens in the sulcus 3-piece here, as the patients are myopic and require an expanded series of lens. So I'm putting in the sulcus, then I remove all the hooks, because it was to support the bag only. Pupil was nicely dilated. Now I'll get the lens in the sulcus and fix into the pupil. See, the bag is absolutely loose here. So no point keeping this lens in the bag. Subsequently, in next 5 or 10 years, the bag will go down. But if you put the haptics in the sulcus, that is also going to support this poor bag also for a long time also. So this will not allow bag to go down in the future also. So all cases with pseudo-exfoliation, where the journals are very weak, high myopic patients, degenerative disorders, you might put the lens in a circle, which is saving the day for all of you. White cataract, I think I'll just go a little briefly here. So this is one case where, so these are young patients and have the too much interlenticular pressure. As you make a nick, it goes to periphery. So this case again, even a needle puncture can have this same scenario also. So you have to be very, very careful in such cases to manage. And how do we save this to happen? Then again, the same thing will come to picture. You have to do a good examination in these cases. So this is a similar case. I've used a high viscosity viscoelastic here to maintain the pressure from the anterior side. The posterior pressure is still there in these cases. So as soon as I make a nick, you can see there's a tendency for a tear to go to periphery. But it did not go to periphery immediately. It gave me some chance, some time to wait. So I made a cruciate incision in this patient so that the transfer of forces get in the 4 areas. So I could prevent the rapid extension of this tear to periphery, and subsequently I could made some sort of oval rexus in this particular case. So this was the advantage of using a high viscosity viscoelastic in these cases. So that is a scenario which can be managed sometimes also. But nothing is better than examination, as I discussed earlier. You can do a good examination of slit lamp, you do anti-segment OCT to picturize them. If you have access to a microscope OCT, that also gives you a beautiful picturization of a spectrum of white cataracts. I'm showing spectrum because each white cataract behaves in a different manner as you puncture the anterior capsule. So if you see, this is a type 1 type of thing. You have a very homogeneous appearance of cortical fibers, and the capsule is not bulging that much. This is a routine white cataract in a senile age group. There's no leakage, nothing happens, and you can do a nice capsulotomy or capsulorhexis for these cases. So this is a type of a white cataract. You can see a total white cataract here. There's a sheets of cortical fiber which are hydrated, but the fluid pockets are underneath these sheets. So unless you cut this sheet, nothing will happen, the pressure will still remain. You can see after initiation, the sheets bulge out. Entire cortex is bulging. So unless you remove this cortex, the pressure will not go down. So surgery is to actually make a small opening first in the anterior capsule, so that you make sure there is a curvilinear opening. Don't make a linear cut here, otherwise you go to periphery immediately. You can see at this stage, I'll put some dispersive viscoelastic here, so that I have a maintained cohesive pressure through the dispersive underneath, and you can take now a small rexus, decrease the pressure by aspiration of a cortex. You can have entire convexity has become concavity. You can do a nice capsulorhexis subsequently. So this is how we judge these cases. This is the third case where you have cortical sheets, they are not complete, they are broken, and you have a lot of clefts and a lot of fluid also. So these cases normally have a milky type of fluid coming, or sometimes oily type of fluid coming. These are cases amenable to needle puncture and aspiration, and you can decrease the pressure immediately in these cases and complete the capsulorhexis. This is a hypermature type of cataract with totally fluid filled, make a puncture, the milk comes out, and surgery becomes very simple in these cases. Femtosecond, I think Dinesh was talking about, sometimes we do have a difficulty there also, especially when you do a laser here. You do have access to a OCT there also. You can picturize what type of thing you have. But the milky fluid release is the main problem in these cases, which causes little bit of adhesion remaining in these cases. So you have to again stain the anterior capsule to save the day, and make sure you do a similar rotation technique as you do for capsulorhexis, so that even a little bit of addition there, that can be taken care of. You can see after the milk fluid release also, you have still a cortical fiber there, which may have a little bit of fluid pocket there. So you have to do this maneuver, especially where you had the fluid release happening in the breast. So that is the area cut. Other area may have addition. So similarly, you have to rotate the rexus and complete phaco in such cases. Nucleotomy is challenged in these cases, and most of the time you have to do a manual phaco, manual chopping in these cases rather than a femtosecond laser chopping here. So this is a small fibrous type of anterior capsule, just to show when you're making the rexus, especially in a difficult cases where you have a nucleus little harder, fibrous type of attachments. So here, because the milky fluid are there, I thought I'll make a slightly smaller rexus in this case. I'll go a little faster here. So you can see rexus here, little bit of, you can see a tearing was not complete here. I'm chopping here. You can see this pressure will go this side, and when you try to separate the piece here, so your left hand pressure is going towards the temporal side. You can see immediately the capsule has torn here. Because my capsule was stained, I could see that area. I bring my second instrument out, but maintain the pressure with the phaco handpiece, use the dispersive viscoelastic at this stage to maintain the pressure onto the tear area. Now I'll withdraw my phaco handpiece. I'll manage this tear by using the second instrument and complete this tear to another rexus. So once the idea here is to see every step of your surgery clearly. If you see the complication happening in the beginning, you can decrease the further complication happening in this case. So I could see the tear happening, and I could manage the tear by not releasing the anterior chamber pressure immediately, which most of the time we make a mistake by withdrawing handpiece abruptly, and that increases tear to the posterior side, and surgery becomes very difficult here. So I could save this, and now I'll make the rexus larger as you shown by the other people also in these cases. This I'll avoid. This is a similar area. In phaco, I'd like to just show you the technique which Dr. Tushar was talking about, because we say in a posterior polar cataract, do a hydrodelineation. But what is not to be done? Hydrodissection. Once you don't do a hydrodissection, your entire nucleotomy becomes very difficult because you can't rotate the nucleus. So once you don't rotate the nucleus, you can't rotate the nucleus. How to do phaco in these cases? So this is the delineation we have done. You can see a very nice delineation. Separate the endonucleus from the epicortical cushion. And the phaco technique for such cases, especially if you have slightly harder nucleus in a posterior polar cataract, where you can't rotate the entire corticonuclear mass. So what we do an initial chop here, because nucleus cannot be rotated. I'll take another piece of a nucleus, take the nucleus out, and I'll take another piece from the left hand side. So this gives us space for an internal hydrodelineation to be done, and nucleus will be free. Now I can tumble the nucleus piece into the center without compromising the epicortical cushion, which is so important in all these cases of posterior polar cataract. So this is the technique described by Avai. Internal hydrodelineation is effectively done by a phaco as such in these cases. So this is what we have realized. Once you do our pieces here, we achieve the internal hydrodelineation happening in all these cases because the fluid gets in. So this is a similar case of a posterior polar cataract where we have created the complication, because if you see the OCT imaging, this is the conical shape, which is one of the high risk imaging of the posterior polar cataract. You can see the image also, typical posterior polar cataract with a defect happening in this case. So this is again the another posterior polar cataract, which is the moth-eaten appearance in the OCT pixelization, and that gives you a high chance that PC might open up in such cases. You can see this is the appearance here. So I've done a good rexus in this space. See the hydrodelineation I'm doing here. This is one way, but I thought I'll do from other side. Just observe center here. You can see the flutter. That means the posterior capsule has given way at this stage. I'll show you again. That is the problem in a posterior polar cataract. What to do now, because I can't rotate this. Again, the same technique of chop and tumble I'll use here. This video is available in IGO now. You can see this is a piece. I'll just take out. Only the endonucleus is manipulated here. The epicortical cushion is there. Now I'll remove the epicortical cushion after I've taken out the entire nucleus here. Very nice fluidics here, which maintains the pressure. I'll take out the cortex, remaining cortex with my handpiece itself. I'll use the dispersive viscoelastic to maintain the pressure, as you saw in other case also. Do aspiration bimanually now. So this gives you a chance that you can maintain the tear and maintain the vitreous face intact here also. Enlarge your incision. Don't do a wound-assisted insertion in these cases. Open the IOL over the rexus. Then tuck your haptics into the rexus margin. It will go inside without disrupting the tear and the posterior anterior vitreous face in these cases. So this is how you can manage lenses. You can do normal surgery in these cases if you maintain the tear and the vitreous face in these cases as such. So this is the completion surgery. We can maintain the entire area also. So this is how entire picturization can be done for posterior polar cataracts also. Femtosecond laser again is the challenge there to have the machine, but if you have the machine, you can utilize them in a best manner to have a best outcome in a difficult scenario like posterior polar cataracts and wide cataract as such. This is the pseudo exploration. I like to go to end of surgery just to remind you what all things we do in these cases. You have to have a good rexis in these cases, 5.5 millimeter. I normally put CTR for all cases of the pseudo exploration. And third important thing would be to implant the lens, which is hydrophobic, single piece in the bag, and do a nice anterior capsular polishing. All cells from the anterior capsule margins should be removed. So three things are important for our pseudo exploration cases. One, good rexis, implant good IOL, put CTR, and capsule polishing is also important for these cases. RK, you all have been doing. The main worry is the incision in these cases. Incision should be managed. If they open up, then you may require to put a persisting suture for these cases. I think just to summarize, you do have a difficult cases coming in your practice. Sometimes we do create difficulties, but it is the important aspect for any management to have a very nice comprehensive pre-op examination, which should be compounded by anti-segment OCT for all difficult cases, especially post-BR surgery patients, poor cases with endothelial compromised situations. There it is very important, and posterior polar wide cataract, so that you know which type of morphology of cataract you are dealing with and what you should do intraoperatively in these cases. Pick up your complication right in the beginning and prevent further complication happening in these cases. The idea is to see what is happening. If you are a beginner, I can understand you see only one dimension. If you grow little more experience, you can see a three-dimensional picture for everything. It's like a driving. Initially, when you learn driving, you see only steering. But once you become a expert driver, you can see all around what is happening here. That same thing holds true for any surgery, and that holds true for cataract also. Again, I'd like to thank the Drishti group of people, not only Gaurav and Saurabh, the entire team, which has done so well for last 25 years. I hope they sustain this for another century with their generation coming, and support the people of this you can say state with the highest technology possible in the manner where everybody is benefited. That means right from the group of people who can afford to a group of people who cannot afford, and that is why their motto they have done well, and wish them all the best for future also. Thank you again for being with us. Thank you, chairpersons also.
Topic so wonderfully well that I don't think there's anything else left. If the new surgeons which are coming up listen to your talk and keep all these things in their mind, problems will be much less. I particularly like that thought of inserting the CTR ring in every case of pseudo exfoliation. That's very essential, because sooner or later the capsule bag is very ढीला डाला है, and it can go down or decenter lens can take place.
That is true. These are progressive disorders. We are not sure if this CTR is going to really prevent, but what concept is, if you have CTR, the back contraction which is happening in these cases is much more than a routine cataract patients. The contraction will have a uniform force 360 degrees. So you would have a lesser chances of some of the joints giving way in one area, because if you don't put a CTR, the contraction of bag is not uniform. So you have more chances of subluxation happening in these cases. That is the idea behind that. Yeah. Thank you again, and
Thank you, sir.
I think we are already getting through the slides.
Thank you so much, Dr. Titiyal sir. Thank you to all the chairpersons. I would like to give a small memento by Dr. Natarajan sir, and I'll invite Dr. S.D. Vijay and Dr. Natarajan sir to please give away small mementos to our chairpersons. Aji.